My guest today is Stuart Azoulay. Stuart Azoulay is the clinical director and primary therapist at Ocean Breeze Recovery. Stuart is a member of the American Association of Marriage and Family Therapists. During his years as a therapist, Stuart provided counseling to those struggling with depression, anxiety, bipolar, eating disorders, and self-mutilation. Stuart specializes in working with substance abuse clients at the inpatient, partial hospitalization, and intensive outpatient levels. Welcome, Stuart.
Hi, Suzanne. Thank you very much.
So great to have you today.
Thank
We're
you.
talking about such an interesting topic, self-mutilation. Let's start with the basics. What is self-mutilation?
Self-mutilation is the direct and deliberate harm to one's body or alteration of one's body, so intentionally harming yourself.
Are there other forms of this behavior?
Not necessarily other forms. It's known as different terms. So a lot of times it's referred to as self-harm, self-injury. Most commonly people refer to it by and large as cutting.
What are some examples of this behavior?
Well, some of the most common examples are slicing of the skin in the fleshy tissue area. Hair pulling, can be head banging, burning. It can go as far as bone breaking even.
Really?
Yeah.
How long, and I guess this really behavior has come about in the public eye, maybe more so in the last maybe 5 years or so?
5 to
But I'm
8.
guessing this has been going on for a while. Why do you think
Absolutely.
we just hear about it now, or it's coming to light now?
I'm guessing that there's more awareness as far as mental disorder and how it affects, with things like the Newtown shootings and whatnot. It brings a light to mental disorders and how they're manifesting and how people are managing with difficult situations now.
So let's talk about the relationship between self-harm and suicide ideation or suicide thoughts. What is that relationship?
Excellent question. It's imperative that whenever you're dealing with a client that is potentially harming themselves, you want to differentiate the difference between suicide ideation and self-harm. You want to assess the client to make sure that they're actually acting out in an effort to relieve or to as far as they see it, benefit themselves, if you will, as opposed to actually trying to permanently harm themselves or end their life.
What are some of the things you would look for to determine that?
What you'll look for is things that seem a little abnormal, like cover-ups, for example, long sleeves or long pants in warm weather. Something that wouldn't be that congruent, it wouldn't fit, Access to or carrying around sharp objects or lighters at times that just don't seem that appropriate.
So what would some of the common myths be about this behavior? Because I imagine those who aren't skilled at understanding it or treating it, they may think, this is a suicide attempt.
Sure.
What are some of the myths around it?
One of the biggest myths is that it's painful. And from an outsider's perspective, we would assume that it is. However, it actually serves a completely different purpose. It's actually not painful. It's a source of relief sometimes for clients. And that's one of the biggest myths, that people think it's painful or that it's a cry out.
So when you talk about it's a release, is the release in the act itself, or is the release sort of in seeing the visual? Take, for instance, if someone was a cutter. Is the relief in the actual cut, or is the relief in actually seeing blood and sort of that concept of now I'm hurting, supposedly, that sort of thing?
Most often it would be in the actual cutting, not the seeing of it. Right. The actual release of the pain will, if you will, bring back the person. And it's like a pressure cooker where they relieve from, basically it's a way of relieving emotional pain. Stress, anxiety, a way of getting them present.
Are there any other diagnoses that kind of coincide with someone who may engage in self-mutilation?
There can be. There are some correlations that doesn't necessarily indicate that they cause it, but it does correlate with various mental disorders, depression, PTSD, borderline personality. Again, though, if someone is diagnosed with one of those disorders, doesn't mean that they will be cutting necessarily.
Right, right. What are some of these sort of cues someone might recognize to say that someone may be engaging in these behaviors? At the beginning of the segment, I talked about wearing long sleeves, or you may see scars, but what are some of the maybe the less obvious signs that people may need to look for?
Some of the less obvious signs would be isolation, depression, feelings of hopelessness or helplessness. Some indicators could be past trauma, abandonment as a child, issues like that can be indicators. And then you want to follow up with the ones we talked about before.
Is this behavior, is it kind of hidden in shame, or is it an outcry for someone, please help me? How does that work?
There's a very, very small population where it is an outcry, but it's not common. The common theme is it's shame-based. It's held and guarded as a secret, as basically it's a maladaptive way of managing distress, and it's held as a comforting tool, as understood by the client.
So when you talk about a maladaptive way of handling stress, what makes someone turn to that as a coping skill? What makes person A turn to that as a coping skill versus person B who says, I might turn to alcohol or drugs or even something that would be healthy? It's
a great question. It's their association. It's the way they understand the meaning of it, what it does for them, what it accomplishes. Each client's going to have a unique way. And you're exactly right. There's a direct correlation. A lot of times to self-soothe or self-medicate, people will turn to drugs or alcohol. So too with eating disorders. And then self-mutilation happens to fall into a similar category. At some point in time, they associate it with relief or a positive outcome.
So I imagine that this would be a very challenging disorder to treat. It must have multi-facet, multi-levels, and because it's going with maybe a co-occurring diagnosis, it must be complicated.
Absolutely, it can be.
How do you do it?
Well, the most important thing that you want to do is you want to make sure to assess the differentiation between suicide ideation and self-harm. You want to get a perspective in the client's worldview. What purpose is it serving? How is it, in their eyes, benefiting them? From there, what you want to do is you want to grow a trust. Form a strategic alliance, a therapeutic alliance with the client, and encourage them to open up and share with you their worldview on how this fits for them in their life, in an effort to elicit alternative responses.
Are there any treatment modalities that are better used for this? So for instance, I hear a lot about DBT when it comes to eating disorders and kind of restructuring the way the mind thinks, or CBT. What are some of the best modalities you've found that help this disorder?
For me, I like a solution-focused modality, which looks at times when the problem wasn't as serious and what was different about those times, so exceptions to when it was going on, and how we could do more of that, how we can bolster that. Another one would be MRI, which is tracking the interactional pattern. So what events lead up to it? What's the feeling afterwards? And how does that cycle perpetuate itself in an effort to interrupt the cycle? How
long does treatment take to, do people recover from self-harm, or do they just learn other coping skills? Do they transfer it to another coping skill? How does that happen?
Yes. Oftentimes it's called whack-a-mole, where one thing comes up and another thing comes down. Right. Generally speaking, people do learn to manage. So I use the word manage because recover is true and it's accurate, but our goal is to identify a more adaptive way of dealing with distress. So clients from substance abuse to eating disorder to self-injury look to get rid of or make go away a feeling, be it anxiety, a trauma, whatever it might be. We look to help them manage it. How do you manage it going forward? How can you more effectively get through life? Because you're going to feel anxious at times. It's okay to.
So when you talked about eating disorders and substance abuse, is there a client that's more prone to self-harm behaviors with that kind of dual diagnosis, eating disorders or substance abuse?
Not necessarily pertaining to the disorder, the diagnosis, more so the demographic. females are more prone than males. Adolescents are more prone than an older population. However, usually it starts at adolescence and can carry through to adulthood.
So tell us about Ocean Breeze and the program there that helps with self-mutilation and substance abuse.
Well, Ocean Breeze was founded by Peter and Kimberly Kogan. They struggled with addiction in their lives, and through their journey into recovery, they identified a philosophy and a perspective on how they wanted their facility to be. What differentiates us from other programs is we work on an individual basis. We treat a client as a whole body approach. So what we want to do is get to know the client. We understand that clients' needs are specific. Their families are specific. Their needs are unique. So we want to tailor their treatment program specifically for their needs. When I say one body approach, we like to say relax, restore, recover. Mm-hmm. So we balance programming, which is individual and group therapy, with recreation, doing things. We also include life skills, vocational skills for those that need it, so they can transition.
Well, for all of our viewers out there, can you tell them how they can be in contact with Ocean Breeze Recovery?
I absolutely can. Go ahead and call our admissions department if you have a friend or a loved one that is in need of substance abuse help or struggling with any kind of a disorder that's disrupting their lives. Our admissions department would love to work with you. Our number is 855-212-7702.
Or your website?
oceanbreezerecovery.org.
Stuart, thank you so much for coming in and talking to us about this topic. I tell you, it's a really interesting topic, and I know a great education tool for everyone watching. Thank you so much.
Thank you so much for having me.